Hi there, my name is Martin Pusic. I have the honor of being the Brigham Educational Institute's Medical Education Scholar in Residence. And what we'd like to do with this series of mini podcasts is to review the Master Adaptive Learner. We presented this as a series of 4 interactive sessions in the BEI, and we'll pull together the nuggets from that in this grouping. This first one is entitled The Overview, and what we're going to do is summarize the Master Adaptive Learner and describe the way it advocates for a metacognitive approach to the way a clinician can learn. So the outline, I'm going to lay out the ambition, and the ambition is a higher one for us in education. We want to be adaptive experts, and so that we'll both define the Master Adaptive Learner framework, and within that say why we have a different North Star. Adaptive expertise. We'll go through the component learning processes in this series of mini podcasts, and I'll just hint at them in this particular overview. This work is the culmination of about 6 or 7 years worth of meetings convened by the American Medical Association as part of its Accelerating Change in Education initiative that started with 11 schools and then bloomed to more than 30, and so that this is a collaborative effort. And the effort was around the idea that lifelong learning needs to be different in 2020. And with the healthcare changing all around us, the former paradigms need to be updated, and hence this work. And we can see that all around us. This graphic is from the St. Louis Federal Reserve Bank talking about jobs and their growth over the last 20 or 30 or 40 years. And what we can see from the graphic is that routine jobs where you do the same thing over and over again in a routinized fashion, have stayed steady, whereas the real growth in jobs has been around non-routine, both manual and cognitive jobs. So jobs where you have to think on your feet and adapt to the circumstances around you. And so these non-routine or adaptive jobs are on the rise, and this is no less true in the health professions. The work from the AMA culminated in this book called The Master Adaptive Learner, and it summarizes the thinking around the group, and it's the content that I'm going to present within this series of mini podcasts. And here, each word of this moniker, Master Adaptive Learner, is meant to have meaning for why we're advocating for something different in the development of clinicians in 2020 and beyond. So starting at the back, the Master Adaptive Learner model advocates that learning is a part of the core identity of a clinician. And so that idea that you used to learn up to the end of your training and then you were fully baked is really not applicable anymore. Clinician has to learn in a lifelong fashion, and even beyond what we've always thought of as lifelong learning, that's part of what they do in their day-to-day work and not separated off into distinct clinical, continuous medical education activities. So here's the model in all its glory, and I'll quickly go through the various elements, all to lay out the landscape, and then we'll go into each of these in more detail. So on the graphic, there's a green circle up in the top right called the planning phase. This 4-part model, which is parallel to the PDSA cycles in the quality improvement world, starts off in the same way in which you plan the learning that you're going to do. And that involves recognizing that you need to learn, and then selecting opportunities and prioritizing what you're going to learn amongst all the things that you could be learning, and then coming up with a plan for doing so. The second phase, planning, is then in fact learning. And engaging in learning, and here what we'll review is the science of learning and the fact that there are good and better ways of learning, even for the excellent learners we get in the health profession, educational training programs. The third part is the assessing phase, in which after having learned, you evaluate how well things went, and did this succeed? Did my learning succeed? And to what extent have I achieved the goals that I laid out? And then the final one is the adjusting phase, and in the adjusting phase, the individual who has planned their learning, learned their learning, and assessed their learning now goes out into the world and uses their learning to make the world a better place. The entire cycle is fed by these batteries that power the learning, and these were carefully chosen. We want learners, and we want to inculcate in our learners and model for them curiosity, motivation, a growth mindset, and the resilience necessary to learn in the face of all the obstacles that can be put in front of us in clinical care. And each of these things can be mediated through coaching. And so the point behind the potentiometer here of turning the raw materials of positive attitude towards learning into effective learning, all told. Here we've broken down separately the 4 phases. And again, what I promise you in the series of podcasts is that we'll go through each of these. But again, organized like a PDSA cycle with planning, learning, assessing, and adjusting, and all of that to bring a metacognitive focus on learning for the health professions. We think of this framework as kind of a coat rack, so that the Master Adaptive Learner framework isn't a theory in and of itself, but it's an agglomeration or a place that we can hang a series of theories and methods that will make us more effective clinicians. And it just as on a coat rack, any one individual coat can vary in terms of its utility and applicability for the environment that you're about to face. The same holds true for the Master Adaptive Learner framework. What we're trying to do is create a shared language or a shared mental model around learning and allow each person to have available to them the educational tools that they need to be effective both for learning and for teaching. What I'm showing now is the Dreyfus and Dreyfus brothers model of expertise development. And it's essentially a learning curve that starts off at the bottom with novices who are not even allowed to practice but are allowed to legitimately participate in the environment. And then gradually, as they become more steeped in the clinical environment, they advance. And they advance first to be able to practice with full supervision, supervision on call, practice without supervision, and eventually the expert in this model is someone who is allowed to supervise other and has achieved expertise. And typically the way this model gets presented is that's when you graduate. You're finished your training. And this generates what I would call an automatic expert, someone who has developed all of the abilities of their profession right at the time of graduation. And so that it's kind of a finish line model, and I've crossed the finish line and I'm done. And so that, but the days of us being able to cross the finish line, even if that were ever true, and being able to continue to practice in the same routine way in ever more polished routines is no longer tenable in a world in which we can't even predict what the healthcare system is going to look like after the next election. What we would graft onto this model is this notion of an adaptive expert, someone who continues to improve as they go out into practice, and in fact, they have been trained to improve. And so it's not just moving the goal line or the finish line further away and asking even more of our learners, but it's in fact to change the nature of what it is to be a clinical expert and to say that it's not about being finished when you graduate, but it's about setting you on a trajectory, and a trajectory that is ever ascending. That you are your own personal improvement project, and thus you have a slope in terms of your expertise development that never goes to flat, but rather you combine all of those elements that are in the Master Adaptive Learner model to keep on evolving within your practice. So I've gone on and on about the learner part of the Master Adaptive Learner model, but we'll get into exactly how that comes across. But the key part of that is the idea of stepping back and in a metacognitive fashion, thinking about how we think. Back now, and the word adaptive can mean a lot of things, and what I'd like to do is spend a few slides thinking about what it means to train someone for adaptiveness or adaptive expertise. And so in a nutshell, it's about discerning the right level of a balance between routine care and your ability to innovate as the situation demands it of you. Here I've put up a blurry slide of a flowchart, and basically it's about do this test, and if this test is above a certain level, go right, otherwise go left, and so on. And it has several leaves, and ultimately the idea is to get to a decision as to whether or not to do CT angiogram or what have you. And so medicine is in many respects becoming becoming richer and richer with these flowcharts. And the flowcharts have gone from a few boxes to, in some cases, many tens and hundreds of boxes in terms of its sophistication. And these flowcharts are routinized care where we have good evidence for when you should go left and when you should go right. And so when these flowcharts exist, that's what a clinician should follow, because they're meant to be the best thinking that we have for a clinical care process. But in many cases, they don't apply. Or the question is, when do they apply? In the unusual circumstances that can arise when a complex patient comes in with a new variant that the clinician has never seen before, or as a general part of their practice, they're having to innovate customized solutions for their patients, that's the province of the adaptive expert. So that what I'm saying here is that there's a balance between training a clinician to invoke routines as embodied by a flowchart and to invoke innovations that allow them to practice the art of medicine when there is no routine or they have to go beyond the flowchart for their patients. So that's often represented with this kind of square, this field, if you will. And so what I'm showing in this slide is a XY square where along the x-axis is the idea of increasing efficiency. So at the far right would be represented as pure efficiency. And then on the y-axis balanced with it is the degree of innovation required of the clinician. And so top of the y-axis is somebody who's a pure innovator, whereas at the top of the x-axis is somebody who's completely acts on efficiency. So frequently in training, we orient ourselves towards efficiency. People who have a compiled routine, who are really, really slick, who are fast, no muss, no fuss, they get on with the work and crank through it. That is a laudable thing, and that to the extent that we can be efficient, we should be in terms of stewarding our resources well. The example I give of a clinical environment that's set up around pure efficiency is the Shouldice Hernia Repair Clinic in Ontario. And so that was made famous by Atul Gawande's book, Complications, in which he talks about the clinic as being a place in which it's almost a factory for hernia repair. So it celebrates standardization. It wants things done in the Shouldice way. And variation is they carefully choose their patients so as they can match their process. And then their process, it's the emphasis is on reliability. And in using these sorts of factory method, but the idea being that they've thought and timed, and with time motion studies and those sorts of things, thought about every aspect of the enterprise, they're able to do the repair in less time, they're able to do the repair with a faster recovery rate, and they're able to do the repair with a lower recurrence rate than people are in places that don't have this emphasis on standardization. So the Shouldice Clinic you can think of as the poster child for a pure efficiency approach. The thing is that you can only do that for carefully selected patients in a context that you control tightly. Think about the opposite pole in which you're completely about innovation. And my joke here is that you're going to develop a vaccine against hernias. And so it requires a lot of blue sky thinking and exactly the opposite of efficiency. And so that you think about exceptional cases, weird cases, cases that offer unique insights into the particular problem, with the idea being to be creative and to bring that creativity to bear on the thing. And so this is the province of entrepreneurs. This is the province of researchers, in which they go deep on the particular problem and want that spark of innovation and are completely willing to sacrifice, or at least to a high extent, sacrifice efficiency. So I've laid out these two poles to suggest that adaptive experts are the ones who can negotiate between these two poles, but in the effective way that best serves their particular context and their particular patients. And so that in this model, being an effective clinician is a combination of your compiled routine expertise, that is your efficiency, and your reflective expertise, you're willing to be disruptive, your willingness to innovate. So that having both of those things in the same person can be highly effective, because then they can deal with whatever the situation demands. And so that the third element of being clinically effective, beyond efficiency and innovation approaches, is the idea of adaptability. It's the idea of being able to switch between an innovation mode and an efficiency mode, and to find the most effective balance between those two. And so what I'm showing now is a graphic from a great article by Bransford and Schwartz from quite a while ago, but in which they've got that x-axis of efficiency, and they've laid it out in 4 squares with low to high, and the highly efficient person being someone who's really, really good at routine clinical expertise. And then they have innovation laid out as low to high, and high being creative exploration. And again, that emphasizing innovation. And in their conceptualization here, training is about having people rub one against the other. And so that you train in something that they call the optimal adaptability corridor. So a range of activities in which you rub routine clinical expertise up against innovation and exploration, and that will lead to adaptive expertise. And so in this model, the thing you don't want to do is to train a surgery resident to a highly, highly routinized way of repairing hernias during their first year of residency, and then pluck them out and then put them in a research lab well away from the clinical sphere for their second year of residency, with a complete emphasis on automaticity perhaps in the first one, and a complete emphasis on innovation in the second one. And instead, they would celebrate a situation in which in doing clinical work, the surgical resident also did quality improvement activities and would present M&M rounds and operations rounds and ways of thinking of doing the routine things better and bringing their innovation to the fore in that sense. So again, to zoom out on the master adaptive learner model, all of these elements, the planning, learning, assessing, adjusting phases married to the batteries and the coaching, are generating clinicians who have adaptive expertise, who are able to properly balance innovation with efficient care. And so again, here's the Dreyfus and Dreyfus model, and here's again that idea of developing adaptive experts who are continually improving, and in our training programs, the idea being to bring metacognitive approaches to bear so that they think about why we do things the way we do them, and not just how to do them more efficiently. This article by Maria Molopoulos, Mahan Kulasegaram, and Nicole Woods is a great introduction to this idea of developing adaptive expertise in education. I highly recommend it. And the 3 things that they recommend that can engender this kind of expertise are situations where the learning emphasizes understanding above pattern recognition, learning that causes the person to embrace struggle and discovery, a certain judicious dose of trial and error, and doing things the hard way is the way you develop adaptive expertise and are best positioned to be effective when the struggle comes in your actual practice. And then the third element is to maximize variation in clinical training, meaning having learners encounter a wide variety of patients and situations, and having to adapt to those situations as being a way of engendering adaptive expertise. And so that you can think that a rotation at the Scholdice Clinic, where every single hernia repair is done in exactly the same way, may have its utility, but it won't be in developing adaptive expertise. So the master adaptive learner model does things differently than in traditional learning, but the emphasis is less on the efficient learning of well-known prototypes and more about developing expertise that can match whatever the situation presents. And so that, again, that idea of learning to cope with variation as opposed to learning well-known prototypes by heart. The unit of adaptation in traditional methods is that we adapt the environment to the learner. So we carefully engineer learning environments so that to keep it straightforward for the learner, hoping to keep them in their zone of proximal development, so keep them in their comfort zone from learning. And that can be very, very important. I don't want to minimize that for early learners. But if we always do that, then we develop learners who don't develop the full ability ability to adapt. And so at a certain point, we have to pivot in which we stop adapting the environment to the learner and instead help the learner adapt to the environment. And this means them stepping out of their comfort zone and de-emphasizing their zone of proximal development in favor of an emphasis on their match to the situation. They're taking on new challenges and seeing challenges as opportunities for learning. And so that the progression is not one of progressively withdrawing the training wheels, but instead the progression is one of adding adaptive behaviors and coaching people for adaptivity. And so the end point of all of this learning is not, as in traditional methods, the full withdrawal of scaffolds, but rather the end point is coaching for long-term improvement. And so that, again, that Atul Gawande idea of even when I'm a fully baked clinician, that I can benefit from coaching and I can always worry about my slope moving in an improving direction. So that's it for this session. I hope we've given you an overview of what the Master Adaptive Learner model is trying to do. It's trying to orient towards a new North Star of adaptive expertise, and it's trying to develop a new language around how we learn, and indeed to embed that in each clinician, that part of their professional identity is as a learner, and that's just not during training, but rather right out into clinical practice moving forward. Thank you very much.